Hello, everyone. My name is Dr. A.K. Singh. I am Senior Consultant Endocrinologist at GT Hospital and Diabetes Institute, Calcutta, as well as I'm visiting consultant at Sun Valley Hospital and Diabetes Research Center at Guwahati. This evening, I'm going to present you one interesting case, and then I will present you how to approach this particular and little complicated case. A 57-year-old man with type 2 diabetes for last 4 years, having hypertension for last 4 years, has been recently detected microalbuminuria. He had a history of acute coronary syndrome 1 year ago. Right now, he is complaining of generalized weakness and presented to you in OPD. If you take the medication history, he is right now on metformin 1 milligram twice daily and getting submaximal dose of sulfonylurea glimepiride 4 milligram once daily, apart from statin antihypertensive drug as well as aspirin. His current laboratory report suggests uncontrolled diabetes with HbA1c of 8.2%, plasma glucose of 198 and prandial blood glucose of 257. I remind you again, he's on submaximal dose of sulfonylurea, glimepiride 4 milligram once daily, and metformin 1 gram twice daily. And this is his current glycemic status. If you look into the renal function, his creatinine is 1.1, and if you calculate eGFR at this age, it's 65 ml per minute. And he has got the urine albumin creatinine ratio of 150 gram per gram at the moment. On examination, everything is fine. His BP is well controlled, as I told you. He is obese. His BMI is 31 kilogram per square meter. The systemic examination reveals no abnormality. His cardiovascular, abdominal, chest findings are perfectly normal. Now let's look into how to approach this gentleman. So to summarize this case, he is a 57-year-old man who had a history of MI a year back. He is known hypertensive and diabetic last 4 years. His sugar is not well controlled at the moment, and HbA1c is hovering 8.2%. His fasting PP is reasonably uncontrolled. Fasting is 157. Prandial blood sugar is 238. Despite that, his blood pressure and lipids are perfectly all right. We need to take care of his glucose control. Now, what to do in this particular case? Now, if you look into the difference between the required target HbA1c of this gentleman, his HbA1c is currently 8.2%. In this particular case, we expect that his HbA1c should be reasonably somewhere between 6.5 to 7%. So he is 1 to 1.5% higher to the target when it comes to the glucose control. Now, how to achieve a good glycemia? Now, when we look into this case, there is one compelling indication that will treat the entire diabetes management. Compelling indication is history of MI. Now, if you look into the guidelines, ADA-ESC guideline as well as ESC-ESC guideline currently recommends that if you have got a history of atherosclerotic cardiovascular disease or heart failure or kidney disease, one has to be either on a SGLT2 inhibitor or GLP-1 receptor agonist. In fact, European Society of Cardiology recommend that someone who had history of MI should be basically first put on either a SGLT2 or GLP-1, and metformin comes as the second line. But since this gentleman is already receiving metformin in a 2-gram dose and sulfonylurea, and it's still requiring good glycemic control, so this case merits a typical indication of using a SGLT2 inhibitor. So naturally, the choice of anti-diabetic drug in this gentleman should be a SGLT2 inhibitor. Now, the SGLT2 inhibitor has got the ability to reduce HbA1c by 0.7 to 0.8%. And in this particular case, we need to reduce HbA1c by 1.2 to 1.5% to come to the target of somewhere between 6.5 to 7%. So we need an additional drug other than a SGLT2 inhibitor that will not provoke hypoglycemia, but will bring down the HbA1c target to between 6.5 to 7. Now, as I said, SGLT2 is a compelling indication in this case because the gentleman has got a history of MI. It is a crime that this gentleman is not yet receiving a SGLT2 inhibitor despite he has got a history of MI. Now, to achieve the HbA1c of 1.2 to 1.5%, we need two anti-diabetic drugs, which is absolutely safe, which is cardiac friendly, which is renal friendly. Remember, this gentleman has also got microalbuminuria, so we also need to take care of his kidney apart from the heart. So we need two anti-diabetic medications which do not have the ability to potentiate hypoglycemia, which is reasonably fine to be tolerated, and which has got the additional ability to protect kidney. Now, the two oral anti-diabetic drug which comes to my mind to be reasonably able to reduce HbA1c by 1.2 to 1.5% would be a combination of SGLT2 and a DPP4 inhibitor. Now, while choosing between SGLT2 and DPP4 combination therapy, we need to be again, evidence-based at the moment. Now, if you look into the basket of SGLT2 inhibitor, in a background history of MI, if you look back into any SGLT2 inhibitor for that matter, the empagliflozin is one exception to the rule in the sense that this is the only SGLT2 inhibitor at the moment which has shown a prolonged survival in the form of reducing cardiovascular death and all-cause death, which other SGLT2 inhibitor could not show in their respective cardiovascular outcome trial. So if I have to choose SGLT2 amongst available SGLT2, I will opt for empagliflozin in this particular. So what about DPP4 inhibitor? As you all know, DPP4 inhibitor has also underwent their respective cardiovascular outcome trial, of which sitagliptin and linagliptin has come with a neutral outcome without any side effects. As you all remember, we had serotonin trial where sitagliptin had shown a significant increase in heart failure hospitalization. There was also some hint with allogliptin, although that was seen in a post-hoc analysis. However, neither sitagliptin nor linagliptin shows any signal of increase in heart failure hospitalization. So if I had to choose between a DPP4 inhibitor, you need to choose either between sitagliptin or linagliptin. Now, linagliptin has got one additional, data, especially in the setting of kidney disease, that it has shown a significant reduction in progression from micro to macroalbuminuria. Although this data is also there with the sitagliptin, but that was only seen in a post-hoc analysis. In the Carmelina trial, the linagliptin shown a significant reduction in progression from micro to macroalbuminuria. So we have got good, riding evidence with linagliptin in reducing or in reduction of progression from micro to macroalbuminuria. Furthermore, a combination of empagliflozin and linagliptin, if you look into the fixed dose combination of available SGLT2 and DPP4, perhaps this two combo has got a best evidence backup at the moment. So to me, the most preferred SGLT2 and DPP4 combination in this particular case, having a history of MI and microalbuminuria, would be a combination of empagliflozin and linagliptin. We don't have any combination of sitagliptin with the SGLT2 inhibitor at the moment. If there would have been a combination of empagliflozin with sitagliptin, you could have chosen this combination. But this combination is not available. So if you look into the available combo of SGLT2 and DPP4 inhibitor, right now the best evidence data lies with empagliflozin and linagliptin fixed dose combination. Now this combination would help this gentleman in giving both cardiac and renal advantage, as well as we could be able to achieve a reasonable HbA1c target of 6.5 to 7%, because a combo of IMPA with LINA would likely reduce HbA1c by 1.2 to 1.5%, and therefore we would be reasonably able to achieve our target in this. Furthermore, the combination of empagliflozin and linagliptin if you look into the data, has not shown any significant increase in hypoglycemia. Now, if this gentleman develops hypoglycemia ever, I would reduce the dose of glimepiride rather than touching the empagliflozin and linagliptin. The combination of impa and linagliptin also has got one advantage that, as you all know, that combination of the SGLT2 and DPP4 inhibitor produces less genital tract infection compared to the monotherapy with the SGLT2 inhibitor. A combo of DPP4 and SGLT2 has been found to have significantly less genital tract infection, as much as less by 50% compared to the SGLT2 monotherapy. So considering this high-risk case who had a history of MI in past and currently having microalbuminuria, so we are dealing with diabetic nephropathy as well, him to use a combination of empagliflozin and linagliptin, which has got the best evidence so far for the cardiovascular protection with empagliflozin and linagliptin, have to some extent of reducing kidney disease by preventing progression of microalbuminuria to the macroalbuminuria. I think the best bet and choosing between the anti-diabetic drug, I would be tempted to use a fixed dose combination of empagliflozin and linagliptin. Thank you very much for your patience listening.